Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is ready. Just sign here. I used to believe that too until I started counting the patients who went in for routine procedures and came out permanently changed. Not better, changed. A man who walked in with back pain and left unable to walk at all. A woman who survived open heart surgery but lost 6 months of her life to complications nobody warned her about. Here's what nobody tells you. The older your body is, the harder it fights just to survive an operation, not the disease, the operation itself. My name is Dr. Mandel, and today I'm going to tell you the truth about 5 surgeries that carry serious hidden risks for people over 60. Before we get into it, one quick thing, because it matters for everything that follows. If you're over 60, or you can feel 60 coming, and what you really want is to live longer, stronger, and healthier, with the independence to make your own choices for years to come, then give me 10 seconds. I took everything I tell my own patients and put it into one simple plan. It has already helped thousands of people live their best life after 60. The link is right there on your screen. You don't need to write anything down. Just take a look once we're done here. And if today's video helps you, do me one small favor. Subscribe, give it a like, and leave a comment. It helps me get this in front of more people who need to hear it. All right, let me ask you something. If you take a brand new car and a car with 200,000 miles on it, and you put them both through the same stress test, do you expect the same result? Of course not. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery expectations, same timelines. That's starting to change, but not fast enough. Here's what happens inside an older body when it goes under general anesthesia. The heart has to work harder. The lungs take longer to clear the anesthetic. The kidneys slow down processing medications. And the brain, this is the one that surprises people. The brain becomes temporarily disoriented in ways that can last weeks or even months. Doctors have a name for it: post-operative cognitive dysfunction. And in patients over 70, it happens far more often than anyone admits. Now, I want to be absolutely clear about something. Age alone is not a reason to avoid surgery. I have operated on 80-year-olds who bounce back faster than some 50-year-olds. Age is just a number, but frailty is not. Frailty is a medical term. It means the body's reserve has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That number jumps to nearly 60% over 85. So here's the real question. It's not whether someone can survive the operation, it's whether they can survive the recovery. Those are two very different things. And that distinction is going to matter a great deal right now. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass grafting, CABG we call it, is one of the most common major surgeries performed on older adults. The idea is simple. Your arteries are blocked, we reroute the blood flow, and for the right patient, it works beautifully. But here's what the brochure doesn't show you. Open heart surgery requires stopping your heart completely. We put you on a bypass machine, a device that does the work of your heart and lungs while we operate. For a 60-year-old in good shape, that's manageable. For a 78-year-old with kidney disease, mild diabetes, and cognitive decline, that bypass machine is a serious assault on every organ in the body simultaneously. Studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here's something that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this surgery. So, what's the alternative? In many cases today, there is one. It's called TAVR, transcatheter aortic valve implantation. a catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic than surgery, but far kinder to a body that needs kindness, not a battle. Does this mean you should refuse heart surgery? Absolutely not. It means you should ask your surgeon one question: am I a candidate for a less invasive approach? That question alone could change everything. Surgery number 2, aggressive spinal surgery. Back pain in your 60s and 70s is almost universal. I don't know a single patient over 70 who hasn't mentioned their back. And the solution that gets offered more and more often is spinal surgery. Fusions, multi-level decompressions, hardware inserted up and down the spine. Now, I need you to hear this clearly. Some spinal surgeries are absolutely necessary, no question. A spinal cord being actively compressed, causing loss of bladder control or paralysis, needs surgical intervention immediately. But elective spinal fusion for chronic back pain in an elderly patient, the evidence is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. 40%. And the most common complications weren't minor: blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion start breaking down because the mechanics of the spine have been permanently altered. The hardware holds one section rigid and the rest absorbs the price. And here's what frustrates me most: the pain relief. Studies show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better, but with dramatically higher risk. I had a colleague, a brilliant spine surgeon, who once said to me, "Sometimes the best operation is the one you don't do." I think about that a lot. Have you ever been told surgery was your only option for back pain? Write that in the comments. I want to know how many of you have heard those exact words. Surgery number 3, major cancer resections. This one is the hardest to talk about because when someone hears the word cancer, the instinct is immediate and powerful. Cut it out, remove it, get rid of it. And I understand that completely. I would feel the same way. But here's what 2 decades in surgery has taught me. The goal of treatment is not just to the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the opposite. Let me give you a real example. Pancreatic cancer surgery, the Whipple procedure, is one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The surgery itself takes 6 to 10 hours. In younger, healthy patients, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away within weeks from surgical complications. Not from cancer, from the operation. This is called futile surgery, and it is more common than anyone wants to admit. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent resection experienced failure to rescue, meaning a complication occurred that the weakened body simply could not survive. So, what's the conversation worth having? Ask your oncologist this question, and ask it directly. If we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health status? That question opens a door many patients never even knew existed, and sometimes the answer behind that door is genuinely better. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are among the most successful surgeries ever developed. I say that without reservation. For the right patient, a new hip genuinely transforms quality of life. People go from barely walking to playing with their grandchildren. It's remarkable. But here is where it gets complicated for older adults. The word elective means the surgery is planned, not an emergency. You have time to think, you have time to prepare, and crucially, time to ask whether this is the right moment for your specific body. Because here's what the statistics show. In patients over 75 with three or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries a significantly elevated risk of perioperative complications. Blood clots are the biggest danger. Deep vein thrombosis, clots forming in the legs, can travel to the lungs and become life-threatening pulmonary embolisms. In elderly patients with reduced circulation, this risk is substantially higher than in younger patients. Add postoperative pneumonia from lying still too long. Add hospital-acquired infections, and the picture becomes much more complex. I want to be precise here because I don't want to frighten anyone away from a surgery that might genuinely help them. The question is not, should I ever have a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular health before elective surgery can reduce complication rates dramatically. Some hospitals now require a formal prehabilitation program before they'll schedule these operations for high-risk elderly patients. And that is exactly the right approach. Has your doctor ever discussed prehabilitation with you before a planned surgery? Most people have never even heard that word, and they absolutely should. Surgery number 5, emergency abdominal surgery. Now, I need to pause here for a moment because this one is different from the others. You don't choose emergency surgery, it chooses you. A perforated bowel, a ruptured appendix, internal bleeding. These situations don't wait for a calm conversation in an office. But here's why it belongs on this list. Knowing the risks in advance, before the emergency happens, changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We're talking 30 to 50% in the most severe cases. Not because surgeons are unskilled, but because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, kidneys, heart, lungs, they all get hit simultaneously. And the inflammatory response that a younger body controls within days can spiral in an older body into something called systemic inflammatory response syndrome. When multiple organs start shutting down in sequence, it is as serious as it sounds. So, what can you actually do with this information? Two things. First, do not ignore abdominal symptoms. Persistent pain, bloating, changes in bowel habits in someone over 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies. That one habit can change everything. Second, have the conversation with your family now. Not in the hospital corridor at midnight. Now. What are your wishes if emergency surgery is the only option? What quality of life matters to you? These conversations are not morbid. They are one of the most loving things you can do for the people who will be standing in that corridor. All right, we've covered 5 surgeries. Now let's talk about what you actually do with this knowledge, because information without action is just anxiety, and that's the last thing I want for you. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. Write these down. Question 1. What happens if I don't have this surgery? A good surgeon will give you an honest answer. If the answer is nothing urgent changes in the next 6 to 12 months, you have time. Time to think, time to get a second opinion, time to optimize your health. Question 2. Is there a less invasive alternative? Medicine has changed enormously in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that didn't exist a decade ago are now available in most major hospitals. Question 3. What does recovery realistically look like for someone my age and my health profile? Not the average patient, you. Your heart, your kidneys, your current medications, your living situation. The answer should be specific, not generic. And question 4. This is the one most people never ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If they seem uncomfortable with the question, that itself is information worth having. Now I want to give you something most patients never get told, because it can change your odds more than almost anything that happens in the operating room itself. If you do decide a surgery is right for you, what you do in the 2 to 4 weeks before you walk through those doors matters enormously. Surgeons spend years mastering the procedure. Almost nobody spends 2 weeks preparing the body that has to survive it. Let's fix that. The first piece is the one we touched on earlier, prehabilitation. It's training for an event because that is exactly what surgery is. Your body is about to run a marathon while you're asleep. So in the weeks before, you build reserve. You eat more protein because protein is what your body rebuilds tissue with, and most people over 60 walk around quietly under eating it. You walk every single day, even just around the block, because the stronger your legs and lungs are going in, the faster you're up and moving after. And getting up and moving is what prevents the blood clots and the pneumonia I talked about. And if you smoke, even stopping 2 weeks before surgery measurably lowers your risk of wound and lung complications. 2 weeks, that's it. I have watched prehabilitation turn a high-risk patient into a routine one, and it costs nothing but effort. The second piece is the conversation almost nobody has, and it's the one with your anesthesiologist. Remember the brain fog I mentioned? Post-operative cognitive dysfunction. There are real practical things that lower the odds of it. Ask for a preoperative anesthesia consultation. Bring a complete list of every medication and every supplement you take, and I mean every one, including the fish oil and the herbal sleep aid, because some of them interact with anesthesia in ways that surprise people. Ask whether a regional or spinal anesthetic, where they numb just the area instead of putting your whole brain under, is an option for your procedure. For many hip and knee operations it is, and it is often gentler on an older brain. And here is a small thing that sounds almost too simple to matter. If you wear hearing aids or glasses, ask to have them with you right up until the moment you go under and back on the moment you wake up. Patients who can see and hear when they wake up get confused far less often. The research on hospital delirium is clear on this, and it's free. The third piece is the part everyone forgets until they're living it: the recovery setup at home. Arrange your help before the surgery, not after. Who is driving you? Who is staying with you the first few nights? Where is the bed? Because the fewer stairs you have to climb in the first week, the better. Clear the rugs and the cords you could trip on. Fill the prescriptions in advance so you're not sending a tired family member out to a pharmacy at 9 o'clock at night. The first 72 hours after you get home set the tone for the entire recovery, and a body that isn't fighting a fall or a missed medication heals faster. Watch for the warning signs in those first days too. Sudden confusion, a fever, a calf that's swollen, hot, or painful. Any of those you call. You don't wait. And the fourth piece, please get the second opinion. I know it feels awkward. People worry they'll offend the surgeon. Let me put that worry to rest right now. A good surgeon expects it. A good surgeon welcomes it because they would want one for their own mother. Bring your scans and your records so the second doctor is looking at the same picture. And if two qualified surgeons looking at the same body and the same images land on two different recommendations, that is not a problem. That is information. That is exactly the kind of thing you deserve to know before anyone picks up a scalpel. None of this is about fear. It is about walking in prepared instead of hopeful. The patient who shows up strong, informed, and organized is a fundamentally different surgical risk than the one who shows up frightened and underprepared, even when the operation is identical. You have more control over which of those two people you are than anyone has ever told you. There's one more thing I have to give you, and it might be the most useful of all because it's about reading the recommendation itself. Over the years, I've learned that the way a surgery is presented to you tells you almost as much as the surgery does. So, here are the warning signs. When you hear them, you slow down. The first red flag is speed. You're being rushed. We need to get you on the schedule right away. Now, if you are bleeding internally, yes, fast is exactly right, and you should move. But for a planned elective operation, real urgency is rare, and a true professional knows that. If a knee that is hurt for 10 years suddenly has to be replaced this month, ask why this month. The pressure to decide quickly is almost never about your body, it's about a calendar. The second red flag is a single path. You walk out with exactly one option, surgery, and no mention of anything else. Remember, by the time you're 70, there is almost always more than one road. Medication, physical therapy, injections, watchful waiting, a less invasive version of the same procedure. If none of those even came up in the conversation, it isn't because they don't exist, it's because nobody put them on the table. The third red flag, and this is the one people miss completely, is that the do nothing for now option is never discussed. Doing nothing, or rather watching carefully and treating conservatively, is a legitimate medical choice. And for many conditions in older adults, it's the right one. If your surgeon can't or won't tell you what happens if you simply wait and monitor, you don't yet have enough information to consent to anything. The fourth red flag is how your questions land. You ask something hard. What is your complication rate? What are my alternatives? What happens if I wait? And instead of an answer, you get a brush off. A good surgeon does not get defensive when you ask the very questions they'd ask for their own family. If the questions make the room tense, pay attention to that tension. It's telling you something. And the fifth red flag is a recovery that gets glossed over. Oh, you'll be back on your feet in no time. That is not a recovery plan. That's a sales line. The honest version sounds different. It sounds like, here's week 1. Here's when you'll need help at home. Here's the part that's genuinely hard. Here's what we watch for. Specificity is a sign of respect. Vagueness, especially cheerful vagueness, is a sign that someone is managing your feelings instead of informing your decision. Now, I want to say something carefully here because it matters. None of this means your surgeon is a bad person. The overwhelming majority go into medicine to help, and they work brutally hard. But you also have to understand the system they operate inside. It is a system that is built around doing procedures, that rewards doing procedures, and that runs on 12-minute appointments where there is no time to walk through 5 alternatives. So, the bias toward action isn't usually personal, it's structural. And the only thing that reliably cuts through a structural bias is an informed patient sitting across the desk asking the questions out loud. So, what does good actually look like? Let me tell you so you can recognize it when you find it. A good surgical conversation slows down. The surgeon draws the problem out for you, sometimes literally on paper. They name the risks before you have to ask. They tell you unprompted what the alternatives are and what happens if you wait. And the very best of them will say the words you're hoping to hear. If you want a second opinion, I think that's a good idea. And here's who I'd send my own mother to. When you hear that, you found someone you can trust. Hold on to them. And one more thing, a small one that does more good than almost anything else on this list. Never go to a major surgical consultation alone. Bring someone with you, a spouse, an adult child, a good friend. Here's why this matters more than people think. In 15 years of practice, I have watched it happen over and over. The moment a patient hears a frightening word, cancer, surgery, blockage, a kind of fog comes down. The mind goes to the worst place, and from that second on, they barely hear another word the doctor says. Afterward, in the car, they can't tell their family half of what was discussed. It has nothing to do with intelligence. It's simply what fear does to the human brain. So bring a second set of ears, someone calm, someone who isn't the one receiving the news, who can actually listen. Have them take notes or, with the doctor's permission, record the conversation on a phone so you can play it back at home when you're calm. And tell that person beforehand the questions you want asked. The 4 questions, the alternatives, the recovery, the complication rate, so that if fog comes down for you, they can ask on your behalf. A frightened patient and a clear-headed advocate make far better decisions together than either one makes alone. Don't walk into the biggest medical decision of your life by yourself when you don't have to. Before I get to the most important part of today, I want to leave you with something genuinely hopeful, because this is not a video about fear. It's about options, and those options have never been more powerful than they are right now. Minimally invasive surgery has transformed what's possible for elderly patients. Laparoscopic procedures, small incisions, camera-guided, dramatically reduce recovery time. Robotic-assisted surgery allows precision that human hands alone cannot achieve. And catheter-based cardiac interventions have opened doors for patients who would never have survived traditional surgery. Beyond surgery itself, and this is something I wish more patients heard, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to require a knife. The body wants to heal. Sometimes our job as surgeons is simply to get out of its way and give it the tools it needs. I want to tell you about a patient. I call him Gerald. 71 years old, retired engineer, sharp as a tack. He came to me after 3 different surgeons had recommended open-heart surgery for a blocked coronary artery. 3 surgeons, 3 recommendations, same answer every time. Gerald wasn't afraid of surgery. He was afraid of losing himself. He'd watched his wife go through a major operation 2 years earlier and come out confused, exhausted, and never quite the same. He told me, "Dr. Mandel, she went in as my wife and came out as someone I had to take care of." That sentence has stayed with me ever since. When I reviewed Gerald's full profile, his kidney function, his frailty score, his cognitive baseline, I sat down with him for 40 minutes, not 15, 40, and I told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehabilitation. The data for his specific profile showed comparable 5-year outcomes between the 2 approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He's standing at the top of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he won the lottery. Here's what I need you to understand. This is the single most important thing I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you have the right to ask every hard question, to request every alternative, and to take every day you need. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine. More powerful than any operation I've ever performed. Let's bring it all together. 5 surgeries